Okay, I'd like to welcome everybody for this evening's webinar. My name is Jody Rudisil, and I'm the Field Marketing Specialist for AXONICS, and I will be the moderator for this evening's webinar with Dr. Lewis Kriteman. This evening, Dr. Kriteman will be speaking about bladder and bowel dysfunction, the common symptoms patients experience, and treatment options that may help you regain bladder and bowel control. Without further ado, I'd like to introduce you to Dr. Lewis Kriteman.
Thanks, Jody. Appreciate it. And I want to welcome everybody this evening for our little chat. We're going to focus almost exclusively on bladder dysfunction. So the AXONICS system that I put in does work on both bladder and bowel, but we're going to really focus more on the bladder for this evening. So important safety information slides that I want to put up talking about AXONICS. So AXONICS is the sacral neuromodulation therapy that we're going to be talking about today, but we're really going to talk about bladder dysfunction in general and urinary incontinence in general, and then we're going to focus in a little bit on AXONICS towards the end. That's kind of what we're going to do here today, and that's our safety slides, precautions, adverse events. The biggest one being find somebody, if you're interested in doing this, who does a lot of this, and thankfully I do a lot of this, and so it shouldn't be an issue from a safety standpoint. So that's a picture of my younger brother. Didn't have nearly as much gray hair. I can't tell if you guys can see my picture. I can't see my picture with the slides up. So that's who I am. For those of you who have seen me, for those of you who haven't, that's kind of what I look like. Like I said, that looks more like my younger brother, but I've been in practice now for over 20 years. I do specialize in voiding dysfunction for both men and women. And I've taught all over the country here and all over the world as far as that voiding dysfunction is concerned. My offices are in Cumming and in Roswell, and that's where I see my patients. I have a team that helps take care of my patients. It's not only me, but it's my PA. His name is Clint. He's been with me for over 10 years. It's my MA, my medical assistant, Ashley, who works with me. And so we try to provide care as a group. And so I think it's important to know that, you know, all your visits, you're not going to always see me. Sometimes you're going to see Clint. Sometimes you're going to see Ashley. But I can assure you that as a team, we make sure that you're getting appropriate care. And at different points during your journey, you will certainly have an opportunity to spend time with me and talk about what treatment options we have for you. So bladder and bowel symptoms can disrupt your life. We know that. You certainly will manage things differently. You drink less before you go out. You miss certain parts of your movies, or, you know, when you're in, with your family, you've got to run around and find bathrooms. And that can affect the way you live. And that's not a small issue. That can be a big issue. And as the slide says, you're not alone. It's a very, very common problem. Overactive bladder in general is seen in about 50 million people here in the United States. And then an additional 20 million will suffer from having issues with fecal incontinence. I think this is key down at the bottom of the slide, though, is that only half of those folks who have severe symptoms ever seek treatment. And to me, that's very sad, because there's lots of things that we can do to help patients. And so not only half of those patients seek treatment, but of those half that seek treatment, most of them don't get appropriate treatment and appropriate education on what's available to help them with their problem. So I think it's important that we understand urinary incontinence. And so I'm going to go through some definitions in these slides so that we're talking on the same page. And so we've got these little circles over here, and this big one over here is overactive bladder. An overactive bladder, we'll talk about the exact definition, but underneath that umbrella, we have urinary urgency. And the urgency, as you can imagine, is you get a strong urge to go to the bathroom. Sometimes you can make it and you are urge dry, and sometimes you can't make it, and that would be OAB wet, overactive bladder wet. And then on this left side, we have stress urinary incontinence. And stress incontinence doesn't mean, hey, I'm stressed and oh my goodness, I've had a terrible day, and that's when you leak. Stress incontinence is when you have increased pressure put on your bladder, coughing, sneezing, laughing, jumping up and down, and that causes leakage. And then we have this middle area here, which is mixed urinary incontinence. So you have some stress, you have some urge. And honestly, most patients really fit into this one that I see, especially on the female side of things, who tend to have some more stress incontinence than males, but we tend to see patients in this little circle over here. So When we say overactive bladder, we're talking about the sudden urges to urinate and unable to hold or control it. When we're talking about urinary retention, that's difficulty urinating or not able to empty your bladder completely. Urinary retention can be somewhat complicated because in a male patient, it can be due to obstruction. So we men have prostates get in the way. You can't void, you can't empty your bladder because the prostate's blocking things up. But the other reasons for urinary retention, which are important in both men and women, have to do with the nerves that come out of the spine to tell the bladder what to do. And if those nerves aren't working appropriately, you can have urinary retention. And then finally, fecal incontinence here on the right is involuntary loss of stool. So normally what happens throughout the day is the bladder fills, and as that bladder fills with urine, it stimulates the nerve endings that are at the bottom of the bladder, what we call the stretch fibers and the stretch receptors. Those stretch fibers and receptors are constantly sending information up these nerves, up through the spine to the brain to tell the brain kind of what's going on. And when they reach a point where things are getting a little full, then the brain sends a message down for the bladder to empty. And so you would think it's fairly simple that that would happen, but it's a lot more complicated than that. And I think one of the things that's important here is step 2 is that the rate of filling depends on your fluid intake. And so the more you drink, the faster that bladder is going to fill up. The faster it fills up, the more frequently you're going to go to the bathroom. And so oftentimes I have patients that come in who have urinary frequency and overactive bladder. And when we get right down to it, we find out that those patients really are just drinking too much fluid. And I always like to tell patients that when they were told that it is important for them to drink 8 ounces or 8 glasses of water a day that are 8 ounces each, so 64 ounces total, that is incorrect, that data is incorrect. It comes from an article in Reader's Digest in 1942. We don't know who wrote it. We don't know where they came up with that information, but it's not correct. And so in the vast majority of us, we have a thirst mechanism that tells us when we need to drink. So the point of my telling you that is I don't want you to overdo it. People think it's healthy to overhydrate and make your kidneys work harder, make your kidneys filter more fluid, and all that's going to do is make your kidneys conk out sooner. So don't overdo it unless you have a specific reason to stay overhydrated. Drink when you're thirsty. Your body will tell you when you need to drink. All right, so getting back to what overactive bladder is. So OAB is the frequent and urgent need to empty your bladder. And then we have underneath that umbrella, we have urinary frequency. By definition, that's voiding more than 8 times per day. We have urgency, the sudden urge to urinate that's difficult to control. Urge incontinence is when obviously you lose urine when you can't get to the bathroom fast enough. And then nocturia is typically defined as awakening 2 or more times in the night to go to the bathroom. And again, if you drink lots of fluid before you go to bed, especially as we get older, you're going to have more issues with getting up at night to go to the bathroom. So what happens with overactive bladder? Typically, what we see with OAB symptoms is that there's an abnormal communication between the brain, the spinal cord, and the bladder. And sometimes the nerve endings in the bladder aren't working appropriately. This may lead to the feeling of an urgent need to go to the bathroom and an unwanted bladder contraction. And when you get that unwanted bladder contraction, that's when you get the, oh my gosh, I'm going to pee right now unless I get my pants right down. And as it says here, you can rush to the restroom and even leak or lose urine before you make it. So why is this important? Well, it affects us in lots of different ways, physically, socially, psychologically, at work, occupationally, certainly sexually, if you're still sexually active. So there's lots of different reasons why this impacts the quality of the life. And why I started off my talk by saying it's not normal, and there are things that we can do to help that. So it's not a normal part of getting older. It's not just a part of being a woman. It's not just an issue with a man having a prostate. It's not caused by something you did or something that you're doing constantly causing the issue. And so the good news is there are lots of different treatments that we can do to help regain control, both of bladder and when there's bowel issues as well. So what are the treatment options? I think this here is a very important slide. I like to put this one up because up on the left-hand corner, it says patient care pathway. And this is a pathway. This is a journey that we're going to take together to try to get you doing the best that you can do as far as your bladder symptoms are concerned. And I want patients to realize that, if we try something and that something doesn't work well, that we're on a journey and we're going to go to step 2 and step 3 and step 4, and we're going to find a way to get you doing the best that you can do. And so I think it's important. I'm going to reiterate again that this journey in this patient care pathway is going to be with my team. So it's not just me, but it's with me, and it's with Clint, my PA, it's with Ashley, my MA, and it's with Mel, who is in charge of my pod. So all of these people are going to be working to help you get through, your workup and all, so that we can get you taken care of and do the best we can do to get your bladder behaving itself. So step 1, consulting with the doctor, consulting with me. In some cases, the first step is going to be with Clint, talking about symptoms, maybe starting a voiding diary. Sometimes we'll figure out how much fluid you're taking in, figuring out what medications you may have tried in the past, what surgeries you've had. If you've had a hysterectomy, if you've had a prostatectomy, all of this information is important on your initial encounter for us to get some idea of where you are on this pathway. And then we're going to start talking about treatment options. And as far as treatment options are concerned, typically we're going to start with medication, but not always. And if you've been on a medication before, we may try a different type of medication. We have newer medications that we use nowadays. What I usually do is get patients back after that first visit to do the workup. Workup's going to include oftentimes a test called urodynamics, and that urodynamics really gives me excellent information about the nerves to the bladder and the bladder muscles itself. And then usually it's going to also involve me looking in your bladder and doing an appropriate exam so that I can see exactly what's going on down in the pelvic region. If we find that, the tricks that we try and don't work initially, then we're going to move on to different aspects of your treatment pathway. Same type of thing with urinary retention. We're going to talk about different ways that we can get you out of retention, get you emptying your bladder better, but we have to figure out first and foremost why the patient's in retention. So a lot of times when we start with some treatment options, we talk about bladder training exercises, we talk about Kegel exercises, retraining schedule, time voiding. I do think it's very important, however, to realize that doing pelvic floor exercises and biofeedback, which we do in our office, and we have special physical therapists that come in, can be very, very useful in patients in helping their symptoms. The problem with pelvic floor exercises and biofeedback isn't how well it works, it's that it's the type of thing you're gonna have to do forever. And so I have patients that think that it's like the surgeries that I do on patients, that I do surgeries and they're fixed. If you do pelvic floor exercises, you're not fixed. You have to continue to do those and do those forever in order to maintain the benefit that you've had from them. Lifestyle changes, I think, can be very important, especially when it comes to the amount of fluid that you're taking in, the types of fluids that you're taking in, whether they're carbonated beverages, caffeinated beverages, alcoholic beverages, all can have an effect on how much urine you make, as well as how your bladder deals with those types of fluids. When we look at medications, the old style medications are the anticholinergics, and this is the Detrol and the Ditropan and the Sanctura and the Enablex and the Vesicare. All of these medications that you may or may not have tried block detrusor contractions. They block the muscles and the nerve endings in the bladder from having so many contractions and allow the bladder to stretch more. If it can stretch more and accommodate urine, you have less frequency, you have less urgency, and it also blocks those contractions, so you have less leakage. The newer medications we have over here are the beta-3 agonists. Those help to allow the bladder to relax even more. Those are the medicines like Myrbetriq and the newest one called Gemtesa, and those also can be very, very helpful in treating patients. When the medications don't work well, when we sort of get through the behavioral modifications and we've tried medications and the medications either don't work well or have too many side effects. And so remember, a lot of these medicines can have side effects as far as drying you out is concerned. They can cause constipation, they can dry out your mouth, they can dry out your eyes. And sometimes it's just the side effect is worse than having the leakage or having the frequency urgency. And patients don't want to do that. So when we run into that situation, the medicine doesn't work from an efficacy standpoint or the side effects are too bad, we get into these advanced therapies. And in advanced therapies, one of them is called Percutaneous Tibial Nerve Stimulation, or PTNS. You come into the office, we put a little acupuncture needle in down by your ankle bone. We treat the nerve that runs up your leg and goes into the spine. This makes it look like it goes into the bladder, but it actually goes into the spine and comes out where the bladder nerves come out. And so it's done in the office, it's covered by insurance, it's covered by Medicare. It has no side effects at all, other than the fact that you got to come into the office for these 30-minute treatments. We do 6 treatments and then we reassess. If you're starting to see improvement of the symptoms after those 6 sessions, we do another 6 sessions, and then we put you on a maintenance plan. And so I have plenty of patients in my practice where PTNS really does work very, very well. They're on a maintenance plan where they come in every couple, 3 months, they get a treatment, and it really keeps those nerve endings doing well. Another advanced therapy that we use is Botox in the bladder. And we do a lot of Botox. I do a lot of Botox in patients whose bladders don't want to behave when they're on medication. Botox is injected right in. This makes it look like we inject it all over the bladder, but we actually inject it down towards the floor of the bladder. We don't do this many injections. Nowadays, we do 10 injections. It works well. The problem with Botox is it wears off, typically anywhere from 4 to 8 months. Most of our patients are on a 6-month regimen where we go back in and we inject some more Botox. So Botox can be very, very helpful in my patient population. And then one of the reasons why we're here today is to talk about sacral neuromodulation, or SNM. This is where the AXONICS system comes into play. What we do is we are going to stimulate the nerves right at their source, where they come out of the tailbone here and go down this little nerve here. This is called the S3 nerve, and it's going to come to the bladder and affect the bladder. And so one of the nice things about sacral neuromodulation is that the way we do is in 2 steps. We do it in a trial first and foremost, which is usually a 3-day trial. And then if the trial works, then what we do, let me see if we've got a picture of that. We don't. Let's see if we can go back here for just a second and back again. If the trial is successful, then we go ahead and we schedule you to put in a permanent implant, and the permanent implant we'll talk about in just a second. So what is AXONICS therapy? How does it work? This is part of our guidelines. And so when we look at the AUA, the American Urologic Association guidelines as to what we should do for patients who have intractable overactive bladder, it's part of our guidelines. It's indicated and approved to treat overactive bladder, urinary retention, and fecal incontinence. How does it work? Well, as we sort of talked about a little bit, it helps to regulate the nerves running from the brain through the spine, going to the bladder and the bowel, and making sure that those nerves are working appropriately, restore the normal communication between the brain, the spinal cord, and the bladder and bowel. The first step, as I mentioned earlier, is this trial period. And what I do in the trial period is I bring in one of my little surgery centers, put you on your belly on a special table. I numb up your back with numbing medication, and I put this little wire down here, which is a little thicker than a hair, into that little hole that's in your tailbone and goes next to the nerve that's going to stimulate your bladder. That little hair thing there, that lead that we call, is going to be attached to a stimulator that's on the outside of the body. We tape everything to your back, and you spend the next 3 days seeing if this is going to work. All right, this is our trial period, and it's nice that we do it this way. And actually, this is the way Medicare says we have to do it, because it gives us an opportunity, and you an opportunity, to see how well this is going to work. And I will tell you, in the patients that I put this little trial system in, that the vast majority, upwards of 80–90% of my patients do see improvement, and we end up going from this trial period to the permanent period. If we put in the permanent implant, this is what it looks like. This is the size compared to a quarter. So it's very, very small. This is implanted. This is the battery, and this is the generator. So this is what's going to send the impulses. The lead is plugged in here. It's going to send the little impulses to the nerve coming out of the back, and telling the nerve what to do. And this little guy, I usually implant in a tiny little incision somewhere around either on your left side or your right side of your buttock. This battery, which is a rechargeable battery, is designed to last for at least 15 years. This newer system, which is better than the old ones we used to do, is completely MRI compatible. So in my patients in the past who needed to have MRIs, we couldn't put these in. And so this is compatible with both smaller MRIs, the 1.5Ts, as well as the 3Ts, and you can scan right all the way down through your back if you need to scan through your back. The patient remote control kind of looks like this. It's very easy to use, but I'll be honest with you, most of the time, once we get you set with the right program and the right amount of stimulation to the nerve, the vast majority of my patients don't need to use this. Once they're set, they're doing pretty well and we leave it alone. When we do the charging for this battery has to be done anywhere from about once every couple of weeks to once a month. It really depends on how much energy you're draining from the battery, what the amplitude is or the power that you're sending through the system to stimulate the nerve. So many patients will just do once a month. You've got this little device here. The little device beeps when you have it in the right position over where that little stimulator is, which again is under the skin, closed up. This is all on the inside. And then charging time, typically 60 minutes or less. In my patients who do this every week to 2 weeks, it's about 30 minutes. When we've done the studies, we found that when we ask patients how easy it is for them to charge after 2 years, 94% say that it's acceptable, 98% charge every 7 days or less frequently than that. This little picture says, yep, charging is easy as anything. Most of our patients who charge, they do it, they're reading the paper, they're watching the news. Very, very easy to do. When we look at axonics therapy as a whole, was this helpful for you? Was this meaningful? Was this lasting improvement? 93% of our patients achieved clinically significant improvements. 94% said they're satisfied with axonics therapy after, a 2-year period. And then 93 said if they had to do it again, they would do it again and expect the same results. Fantastic to be able to live a normal life again. And this is not a problem that only affects some of my male and female patients that are older. I have plenty of patients who are in their 30s and their 40s who do have neurologic issues going to the bladder, and this can be very helpful for them. So that's our little talk on axonics, what it is, what it means, why it's important, and what it can do for you. A few slides here on the other type of incontinence that we see, which is stress incontinence. So if you leak when you sneeze, exercise, laugh, jump up and down, cough, just in walking, that may be stress incontinence. And so normally the bladder functions by filling up, and as the bladder fills, this urethra is contracted. So this tube here is the urethra, and the nerves are constantly telling the urethra to stay contracted. When we empty, the brain sends a message to the bladder to go ahead and start to push urine on out. It also has to send a message here to the sphincter to tell this to relax so that the bladder isn't pushing against a closed system here. So what happens with stress incontinence? Well, the urethra, or rather the bladder, fills on up and the urethra stays strong in a normal situation. In somebody whose urethra is somewhat weakened, what happens is when there's pressure to the bladder, coughing, sneezing, jumping up and down, and that pressure is applied here, the urethra can't stay closed. This sphincter muscle is weak. And when it can't stay closed, urine leaks on out. So again, you're not alone if this happens. Stress incontinence occurs in about 1 in 3 women at some point of their lives. Like we saw before, this can really impact lifestyle. So mental health, physical health, productivity, economically, this really can affect patients. Good news, same picture. There are treatments that can help with that. So what do we do for stress urinary incontinence? This tends to be more of an issue in my female patients than it is with my male patients. We men have prostates. It keeps us out of trouble as far as stress incontinence is concerned most of the time. But in my female patients, we can talk about pelvic floor exercises. So this is going beyond the Kegel exercises that you learned after childbirth. This is truly doing biofeedback and pelvic floor physical therapy to strengthen the muscles down there. As I mentioned before, it can be very helpful, but it has to be done every day and every day the rest of your life. We have surgical slings. So we still put slings in patients. This is the gold standard treatment for most patients with stress incontinence. We have urethral bulking, which we'll talk a little bit about today. And so when patients come in and they only have stress incontinence, again, we're going to have a journey. We're going to get you worked up. We're going to talk about what treatment options are. And then we're going to sit down and we're going to figure out what the best way is to get you drier. And so when we talk about pelvic floor exercises, again, this is Kegels and things like Kegels, but we go beyond that in our practice and in my group in getting you set up with the physical therapists and making sure that you're doing your exercises correctly because they show you how to do it. And then you go home and you got to do it every day. And typically you come back to make sure that those exercises are doing what they're supposed to do. When we do slings, we're talking about putting a tiny piece of Gore-Tex mesh underneath that urethra. So the sphincter is right in here. And if we can give that some support, then patients end up doing a lot better when that pressure is put on the bladder. So leaking less with sling. We see 80 to 90% success rate with 17-year follow-up. It's about that with 20-year follow-up as well. As I mentioned before, it's the gold standard by many for the surgical management of stress urinary incontinence. It's also a little bit more invasive. So this, I do what's called a mini sling, and I do this through a small vaginal incision on the roof of the vagina. So that's right underneath where this urethra is. But it's a surgery that, has to be done in that manner. And we are using mesh. We still have found mesh to be by far the best way to do this. We have also found that the smallest amount of mesh you can use is the best way to get by as far as doing, sling surgery for patients. Lastly, we have urethral bulking. And so we saw those pictures before, looking at that bladder and looking at that bladder neck down in this area. If we can bulk that up, if we can make that donut hole smaller so that it's harder for urine to slip through, that can be very helpful. So we want to bulk up the walls of that donut hole. This can be done in a outpatient setting. It can be done even sometimes with a little bit of local lidocaine. Sometimes we'll do it with some minor sedation, but really helps to reduce urinary leakage from stress incontinence. So the product that I use for this is called Bulkamid. It's a minimally invasive non-mesh alternative to treat stress urinary incontinence. It's a soft material. It's water-based gel, clinically proven to help improve and cure stress incontinence. And so what I do when I do this type of procedure is I look in your bladder with a little microscope. So the urethra is right here. And I actually inject this material in 4 spots around the urethra to make this donut hole right here smaller and give it more support. And these are what we call the Bulkamid cushions that we put in there. So once we do that, put a little catheter in, send you home, get it out the next day. So 92% safe and effective in women as far as curing or improving their stress urinary incontinence. It's a simple procedure. It usually takes me about 5 minutes, and we do have good long-term data. The other thing I like to say about Bulkamid is if I do Bulkamid on patients, I don't burn any bridges. Meaning if we do Bulkamid and it doesn't help as much as we hoped it would help, we still can then go and do a sling if we need to do a sling, and vice versa. I've had plenty of patients who I've done slings on who just want to get tweaked. They're not as dry as they, had hoped to be. And what we do in that case is we do some Bulkamid cushions to help them with their incontinence. So if you're ready for symptom relief and you're ready for getting started on your pathway that we talked about, what I would do is I'd like you to give us a call. Here we are at this slide here. This is the general number for our office. And what I need you to do, if you want to sort of get this pathway going and get the ball rolling, is call and leave a message for Ashley Pearson. And then one of my gals will get back to you. So when you call and say, I want to speak to Ashley Pearson and I'm calling about AXONICS dry because I want to get dry and I want to get dry using the AXONICS system or Dr. Kriteman's team, what will happen is someone will give you guys a call back, get you an appointment. Sometimes that appointment's going to be with Clint, my PA, as far as the first point of contact. Sometimes it's going to be with me. It just depends on how quickly I can get you in on the schedule. But during that pathway, like I said, I take a team approach as far as getting you worked up appropriately, talking about what the different treatment options are, any surgery that needs to be done. So if we're doing AXONICS, sacral neuromodulation, that's me doing that. No one else will do that. If it's Bulkamid, that's me. If it's slings, that's me. And so I'm doing all the surgery. It's just I need a team to help me get you worked up appropriately. And so with that, I'm going to hand it back to Jody.
Perfect. Thank you, Dr. Kriteman, so much. We appreciate listening from all your experience with treating patients with bladder and bowel dysfunction. And we are going to now answer some questions. So let's start with a few here, Dr. Kriteman. Is there any data with AXONICS for Parkinson's patients?
That's a great question. And as we know, Parkinson's affects the muscles in the body, all throughout the body. It does affect the bladder. It affects the sphincter that's at the bladder. I have had some patients who have Parkinson's disease who do have bladder dysfunction that we have done sacral neuromodulation on, and it has improved their situation. That being said, it's not specifically what AXONICS sacral neuromodulation was meant to do. We have had some success, and especially in patients who have tried everything else and can't seem to find anything to help them. As a last ditch effort, we've done some of this, and it has been helpful. Somebody with Parkinson's is a little bit more complicated than just your general patient who has overactive bladder with and without leakage. And so the workup might be a little bit more extensive for those patients. But great question. And yes, we have had some success with that.
Perfect, thank you. Is it normal for somebody over 75 to have this issue, either stress or urge urinary incontinence?
I guess it depends on how you define normal. There is no doubt that as we get older, muscles and ligaments change, body habitus changes. And so I will say to you that, is it common for women, for instance, as they get older, who still have all of their organs down there, you still have your uterus and ovaries, and even in those who don't, for things to sort of, I'll put in quotes, fall down or fall out and have more leakage? The answer is yes. Even though it may occur more frequently as one gets older, doesn't mean there isn't something that we can't do to help the problem. And so, yes, I see that much more frequently as patients get older as far as the stress incontinence is concerned. And yes, as we get older, believe it or not, our bladder gets a little stiffer. It gets a little less elastic, a little less compliant. It's not able to hold as much urine. And as a result, it doesn't stretch as much. And when it doesn't stretch as much, we get more frequency and more urgency. And the only other thing that I'll mention is, as we get older, we tend to make more urine at nighttime. And so I always get the question, Dr. K, does getting up at night happen more frequently as you get older? The answer is yes. So we make more urine at nighttime as we get older. Our kidneys become a little less sensitive to some of the hormones and enzymes that float around the body and tell it to keep more urine in the bloodstream. So we lose more water at nighttime. And then we become puffier as we get older. And as a result of that, the tissue fluid tends to come back into our system at night, and our kidneys say, well, gosh, you don't need all of that fluid, and it puts more urine into the bladder at nighttime. So I will tell you that it is normal as you get older to make urine at night, more urine at night than you did when you were younger.
Perfect segue to this question. Was a normal time a male over 65 would get up in the middle of the night to go to the bathroom?
So I guess the question is, what's a normal number of times that a male will get up at nighttime? So if the guy is 65 years old, the normal number of times to get up would probably, if I look at an average, 1 to 2 times per night. So all of my patients that come in, when you're 75 years old, average is going to be more 2 and a little over 2 to 2.5 times per night. And even though that's normal, even though we see that frequently, so if patients come into me and say, Doc, I get up twice at night, I get right back to sleep, is that normal? Is that okay? The answer is yes. If the patient comes into me and says, Doc, I get up 2 times a night, I can't get back to sleep, I'm miserable, is there anything we can do about this? The answer is yes. And so we get you worked up to see what we can do to get you going less frequently at nighttime.
Perfectly. Would Bulkamid work for males?
Bulkamid's not FDA approved for males right now. There are other things that I do inject in male patients, especially those who have had prostatectomies. So if you've had your prostate completely removed for cancer reasons, for instance, and you're having some leakage, I do inject other products in and around the bladder neck to try to make that donut hole smaller. But as of right now, AXONICS is not FDA approved for men. I'm sorry, Bulkamid is approved for men.
Thank you. I've had InterStim implant. It is not effective at all. Would the percutaneous treatment be something that I might be able to get relief with?
Yeah. So if you've had an InterStim, which is a product that Medtronics came out with years and years ago, there are 2 things I would say about that. Number one, that the newer devices that we have, especially the newer AXONICS device that we have, may do a better job of stimulating the nerves in the back. And so I've had several patients, actually more than several in my practice, who we swap out the AXONIC sacral neuromodulation units for the older InterStim, who do very well with the newer sacral neuromodulation devices. So that would be number one. Number two, I have had a few patients that can get some improvement with percutaneous tibial nerve stimulation who have an InterStim in, and it's been in for 10 years. It's turned off. They don't even use it anymore, because essentially what we're doing is stimulating the nerve somewhere along the pathway. With the percutaneous tibial nerve stimulation, you stimulate it at the ankle bone to get it up to the back, to get it out to the bladder. Typically, that's not going to work as well as right at the source when you put in an InterStim or you put in an AXONICS unit. But I have had some patients get some relief with that.
So this one is just says, does this work for stress? I'm thinking this is talking about AXONICS.
Yeah, so the AXONICS will not help stress incontinence. It will, that's where the Bulkamed comes into play, or the slings come into play as far as improving stress incontinence. And likewise, if I do Bulkamed on somebody and they have stress incontinence, it will not do very much for the urge incontinence. And so those are two separate types of things that we treat differently. As I mentioned at the outset, a lot of patients have a little bit of both. And so sometimes we need to talk about, okay, we're going to take care of your stress incontinence first. If that's more bothersome, we'll see how you do. If you're still having issues with the urge incontinence, then we go ahead and we talk a little bit more about the sacral nerve modulation, neuromodulation.
Nice. Perfect. Thank you. Is AXONICS covered by insurance?
Yeah, great question. So right now, AXONICS is covered by all the insurances that I see. And I think I could take care of all insurances. So I haven't had anybody turned away by insurance, especially Medicare, as long as we do it the way they want us to do it, meaning in the two-step program to make sure that it's going to work, because Medicare, for instance, doesn't want us to put something in if it's not going to work. So that's why we do the temporary one to see if it's going to help over a couple of days. But yes, this is absolutely covered by insurance. So very good question.
Perfect. Thank you. This one we touched on briefly earlier. Would AXONICS be effective after having a prostatectomy, radiation, or radioactive seeds near the prostate bed?
Yeah, great question again. And yes, I've had a lot of success in patients and male patients who've had prostatectomies who have intractable overactive bladder and or leakage, mainly because of the radiation and the effects from that radiation. And we go ahead and we put in an AXONICS unit, those folks can get quite a bit of relief. Still need a workup, and we still need to make sure that we don't see any obstruction in the prostate, any scarring from the radiation, because that can affect things as well. Assuming there's no scarring and there's no obstruction, then yes, absolutely, we can talk about putting in a sacral nerve modulation unit.
Perfect. Thank you. With AXONICS, with the trial and or the implant, how soon would I be able to go swimming?
Oh, great question too. So with the trial, you can't go swimming. You can't shower. It's a 3-day trial and the little leads are coming out of your back. It's all on the outside. And so you can't get wet back there. So we put a bunch of saran wrap and wrap everything up so everything looks good. But that's only for 3 days. Once I have the permanent implant in and the little incision where I put that battery stimulator heals, I usually tell my patients 5 to 7 days before you can get that area, submerge that area, meaning in a bathtub or going in a pool and going swimming. So 5 to 7 days just to allow that little incision to heal. After that, you're good to swim to your heart's content.
Okay. This is a good one. If I've had back surgery, could I get AXONICS?
Yeah. So most back surgeries that are done are typically in the lumbar region. So L4, L5, L5S1. Some people are thoracic or higher cervical. We're operating below that. So this is down in your tailbone, down in your sacrum. And so I haven't had anybody who's had sacral surgery before. Sometimes folks break their tailbone, their coccyx, and they can sometimes have surgery on that. That would be the only instance where we might have an issue, but I've not run across anybody in my 23 plus years of doing this that I wasn't able to do this type of procedure, sacral neuromodulation, who had had prior back surgery. So if you've had the back surgery, it shouldn't be an issue.
Perfect. Could a body reject the implant?
That's a good question. I have not had anybody who is whose body is allergic to the materials that we use. This is surgical grade stainless steel. This is nitinol, which is a special type of alloy. There is a little bit of nickel, but the nickel is actually wrapped inside of the stainless steel and the nitinol. I've not had anybody who even has a nickel allergy have any issues with this. And so in my experience, I have not seen that.
There's a question about if somebody's sister has a prolapsed uterus, could AXONICS work? And I will just they're wanting to know more information about the treatment, so they could go to axonics.com. But if you could answer something regarding a prolapsed uterus.
Yeah, so if there's prolapse of the pelvic organs in a woman, so the uterus, the bladder, the rectum, all are sort of pooching out through the vagina, typically that needs to be dealt with surgically. You've got to sort of reorient everything into their correct anatomic position. So in the case of the uterus, sometimes doing a hysterectomy, sometimes pinning things up, after which, if the patient's still having bladder symptoms or even bowel symptoms, that's when we would talk about putting in axonics. But taking care of the anatomic defect first is going to be important. You wouldn't want to leave somebody who has severe uterine prolapse or vaginal prolapse putting in an axonics, because it's probably not going to work nearly as well as it should until you take care of the issue with that severe prolapse. So
Perfect.
that's where, having an exam and making sure that everything, is appropriate. That being said, I've got plenty of patients who have minor prolapse, minor cystoceles, enteroceles, rectoceles, minor vaginal wall prolapse, who we do this procedure in, and they can do just as well as if they didn't have minor prolapse. But major prolapse, I'd probably want to fix first.
Would there be any complications to get axonics if I have a pacemaker?
No.
Good. And are there any long-term negative effects with either axonics or Bulkamid?
No. I guess let me Bulkamid first. So the material that Bulkamid is made of is made to last and made to stay where we put it, so it doesn't get absorbed by the body and it doesn't break down over time. I've not had anybody have issues with Bulkamid in the short, intermediate, or long term, as far as long-term side effects are concerned. With the axonics, sacral nerve modulation, I guess the only issue that you could potentially have would be infection of the leads going into the back, or where the little stimulator generator is in the buttock pocket that we make. Thankfully, the way we do it, giving patients IV antibiotics, washing everything with antibiotic washes, being very sterile. I suppose you could have a perioperative infection right around the time we do the procedure, but long-term or intermediate term, there should not be any issues with that. No.
I think I've got one more. I really appreciate everybody's time. And I think we've covered this one, but I just want to make sure, if I had a prior test with another product, could I get a test with axonics?
Yes.
Okay.
So there shouldn't be any issue, even if you've had a prior test phase with, let's say, Medtronic's InterStim. You did what we call a PNE, a peripheral nerve evaluation. We can still then go and do a PNE with the axonic system. They're different systems. They work a little bit differently. They're different leads. And so I've had plenty of patients who failed a prior Medtronic's trial who do end up doing well with axonics.
Oh, we got one coming on, which I think we might want to answer for everybody. How long have the implants been in use?
So axonics implants have been in use now, I think we're pushing on 5 years as far as, how long have we been using them. But the technology that Medtronics initially put into play has been around for about 25 years. And so the technology's been around. It's just the types of leads that we use, the type of batteries that we use, and then the way we stimulate, the way we send the messages from the generator to that nerve, those have changed as well. So been around for a while. It's got a great track record as far as helping patients with their overactive bladder and their leakage.
Okay, good. We had a few more questions. If we didn't get to your questions, thank you, Dr. Kriteman.
Yep.
Please call Dr. Kriteman's office, and again, ask for Ashley Pearson. And so if we didn't answer it or get to it, I just want to let you know to call in. We appreciate everybody's time. Thank you, Dr. Kriteman. Thank you, everybody, for joining, and I hope you all have a wonderful evening.
Thanks for putting it together, Jody. Really appreciate it. Thanks.
Great.
Good night,
Thank
everybody.
you.